completed her medical education at Pondicherry University in India, and subsequently pursued a master's degree in public administration from Drake University. She then went on to complete her general psychiatry residency training at Bergen Newbridge Medical Center. And she is currently a child and adolescent psychiatry fellow with us here at Phoenix Children's. She also completed a ECT mini fellowship at Emory University. Please join me in listening to her talk on innovations in interventional psychiatry, enhancing mental health through targeted interventions.
Thank you, Dr. Ritfield. Good morning, everyone. Thanks for joining me for today's Grand Rounds. As Dr. Ritfield mentioned, today's our topic is innovations in interventional psychiatry, enhancing mental health through targeted interventions. Okay, so let's begin with a review of nomenclatures. Neuroplasticity is the ability of the nervous system to change its activity in response to intrinsic and extrinsic stimuli. Neuromodulation is a technology that acts directly upon the nerves, leading to the alteration and modulation of the nerve activity. An interventionalist is a physician who is certified by nature of training and experience to perform interventions that are procedural and typically more invasive than general medical care within that specialty. The evolution of interventionalism first started with cardiology, was the first medical specialty to grow interventional subgroup, borrowing techniques from radiology such as fluoroscopic, using them to image vascular occlusions, and also develop techniques to convert aberrant electrical rhythms back to normalcy. As with cardiology, neurology realized the electrochemical nature of the brain. TMS emerged as a non-invasive tool to study cortical excitability and neurophysiological function of the brain. Neurology used the concept of pacemaker and developed implantable VNS, RNS, and DBS. As these technologies were used by neurological indication, it became evident that there were psychiatric side effects and benefits associated with their use, paving the path for interventional psychiatry. Interventional psychiatry is an emerging field of psychiatry that utilizes procedure-based treatments to alleviate mental distress, often when traditional pharmacological and psychotherapeutic treatments have failed. On broadly classifying treatments in interventional psychiatry, it is either treatments involving devices or medication therapies that require monitoring, such as ketamine, brexanolone, psychedelics-assisted psychotherapy. Treatment involving devices are again subdivided into seizure-generating and non-seizure generating, such as ECT, which is a seizure-generating electroconvulsive therapy, and non-seizure generating are transcranial magnetic stimulation, vagus nerve stimulation, deep brain stimulation. And as we go further in our presentation, we will learn about these different modalities. Let's begin with the history of ECT. In 1935, Manfred Sekel used insulin shock therapy by inducing hypoglycemic episodes in psychiatric patients. In the same year, Lazo Meduna injected chemicals to induce convulsions to treat psychosis. In 1938, Italian psychiatrist Dr. Ugo Carletti used electroshock to induce psychosis. Electroconvulsive therapy was already an established treatment for psychiatric disorders when FDA began to regulate medical devices via the Medical Device Amendment Act in 1976. In 1976, FDA gave grandfathered approval for ECT devices and classified it as Class 3 device. And finally, in on December 2018, FDA issued a final order regarding reclassification of the device as Class 2. Despite extensive clinical use of ECT for more than 70 years, its mechanism of action is poorly understood. Theories such as psychological, psychodynamic concepts to theories involving neurotransmitter changes, neuroendocrine effects, intracellular signaling, and gene expression have been proposed to understand the mechanism of action of ECT. Anticonvulsant hypothesis is one of the most popular theories defining mechanism of action of ECT. It hypothesized that the antidepressive efficacy is directly correlated with the anticonvulsant effect of the ECT. That is, a successive ECT treatments causes both an increase in seizure threshold and decrease in seizure duration. This theory focuses on neurotransmitter system and intracellular biochemical processes. So let's learn about neurotransmitters. When comparing the receptors pre-ECT and post-ECT, researchers have found that ECT effects on different receptor systems. So first begin with adrenergic receptors. Certain antidepressants act on adrenergic receptors, and similarly, ECT has its effect on increasing the norepinephrine turnover. It increases alpha-1 adrenergic receptor sensitivity and decreases alpha-2 adrenergic receptor sensitivity. On glutamate receptors, there are two groups of scientists have reported two different studies. One which suggests that the glutamate concentration decreases after ECT and associated with neurogenesis and clinical improvement. The other group of scientists, such as Cano and his colleagues, reported that glutamate concentration increases after ECT, causing neuroinflammation and promoting angiogenesis, which is a part of neurogenesis process. Abbott and his colleagues reviewed 26 studies performed between 2002 to 2013, and it showed that patients who responded to the treatment were noted to have increased normalized glutamate level after ECT. Similarly, GABA receptors also show the increase in gamma aminobutyric acid levels post-ECT on certain parts of the brain. However, these studies do not show any correlation between the changes and clinical response. Dopaminergic receptors were studied in a two different D2 family and D1 family. D2 family is mainly after post-ECT. It was noticed that there is a less affinity for the neurotransmitters. But for the D1 receptor family, they have noticed that upregulation of the D1 receptors and increased affinity for the the dopamine, which is responsible for neuroplasticity. And for the serotonin system, ECT affects serotonin system and BDNF through an increase in serotonin levels, which promotes neuroplasticity through the BDNF synthesis stimulation. However, ECT also causes increase in pro-BDNF level, which promotes neuronal apoptosis and antiplastic effects. The role of TPA is important as it is used in the transformation of pro-BDNF to MBDNF, and it appears as responsible for the neuroplasticity, this specific role. Intracellular biochemical processes, Hingeman and his colleagues in 1987 reported that there is evidence of upregulation of delta opioid receptors, binding sites after repeated seizure. And in 1987, Total and his colleagues theorized that anticonvulsant substance is likely to be endogenous opioid produced after ECS in rodents. Treatment with naloxone blocked the anticonvulsant effect of ECS. Whether similar changes occur in humans is speculative, and to date, efforts to lengthen the ECT-induced seizures using naloxone have not been successful. Adenosine is an important inhibitory neuromodulator that acts on several receptor types, is released extracellularly during seizures, and play a role in seizure termination. McCall and his colleagues reported that adenosine receptors antagonists such as caffeine and theophylline prolong the ECT-induced seizures with less effect on seizure threshold. Now let's learn the neurobiological effects of the ECT. The use of different imaging techniques, we recently identified that there are 3 stages during the ECT. The first one is ictal phase, where there is an increase in blood flow, increase in brain glucose metabolism, and increase in cortex oxygen consumption, followed by post-ictal phase and intra-ictal phase. In the post-ictal phase is the most important one, as there is decrease in blood flow as well as brain glucose metabolism, and is associated with ECT efficacy in the depression treatment. Similarly, it has also been reported that ECT acts on the neuronal structure volume. Josh and his colleagues evaluated 32 control patients and 43 patients with major depression before ECT, after the first session, and after 1 week of completing the ECT treatment. They observed that before the beginning of the treatment, the patients with major depression had smaller hippocampal volumes than the control patients. And after ECT, the hippocampus volume is increased and with the improvement of the symptoms. So this hypothesized that patients with lower hippocampal volumes before ECT tend to present with higher volume increase and better clinical response. So this is a diagrammatic representation of hypothalamus. Alter and his colleagues have proposed that ECT acts by increasing neurogenesis in subfields such as dentate gyrus here, and granular and molecular level of the dentate gyrus, along with subiculum here and cornus ammonis. So ECT has shown improvement in symptoms in different psychiatric disorders such as depression, psychosis, OCD, and PTSD. Studies published on ECT effect on depression with bipolar or unipolar all showed positive response of ECT. A meta-analysis study on 19 randomized clinical trials reported the response rate was significantly higher for bipolar depression than unipolar depression. So what are the FDA indications for ECT? FDA approved ECT for the treatment of catatonia, or a severe major depressive episode associated with major depressive disorder or bipolar disorder in patients aged 13 years and older, who are treatment resistant or who require a rapid response due to severity of their psychiatric or medical conditions. So there are some pre-ECT workup and instructions we give to the patients. Pre-ECT workup is mainly clearance from the anesthesiologist, general lab workup like a CBC, chemistry panel, COVID testing, pregnancy testing, EKG. And the instructions what we give to the patients is if the patient is on lithium, we recommend not to take medication the night before ECT and the morning of ECT. They can resume taking this medication after the ECT because there is a risk of delirium post-ECT. Dopamine agonist also, we've seen that patient gets confused after ECT, and hence we recommend they can take the medication the night before, but the morning dose can be taken after the ECT. Blood sugars are very important to control. We recommend to have a follow-up with the internal medicine or a general pediatrician If the blood sugar is more than 200, we recommend to have a sliding scale. Theophylline is something which is known to prolong the seizures. We recommend not to change any other medications if possible, as it can affect the treatment. Blood pressure medications, patients can take blood pressure medications on the day before. We don't recommend to stop the medications. They can take the morning of the ECT. We recommend to hold the Lasix down. And it is also very important to assess patients' cognition, cognitive assessment as the treatment process proceeds. So the first cognitive assessment needs to be done before the first session of the ECT. And we recommend to do electroconvulsive therapy cognitive assessment scale because it includes the autobiographical information. And as the sessions progress, it can be done like in the third session, in the sixth session, but the first needs to be done to have a baseline. There are no absolute contraindications for ECT. However, there are some relative risk factors. Like for psychiatry, we need to screen for suicide risk. We need to get good collateral from the family. And if at all the risk we see, we need to make a good safety plan. Similarly, like for cardiology, uncontrolled hypertension, recent MI between 4 to 6 weeks, unstable angina, decompensated congestive heart failure, aortic stenosis, uncontrolled atrial fibrillation, unrepaired abdominal aortic aneurysm more than 5 centimeters, and pacemakers needs a cardiology clearance. Similarly, we need a neurological clearance if the patient has cerebral infarction or hemorrhage, symptomatic intracranial lesions like headaches, papillary edema, focal neurological deficits. And for patients who have asthma and COPD, they can get ECT. However, if the oxygen saturation is less than 90, we need to be very careful. One of the complications is aspiration pneumonia in patients who are not on NPO, or patients who are obese, like BMI is more than 50, or pregnant patients. DVT prophylaxis is necessary for the patients who have catatonia to avoid PEs. Pharmacology of the ECT. There are some medications which we give prior to the ECT session, such as anticholinergic agents, glycopyrrolate. This is mainly to reduce the respiratory secretion and salivary secretions to have a better airway during the treatment. And if we choose to give, it should be given like approximately 20 minutes prior to the session. Approximately 50% of the patients report headache after post-ECT. In those cases, we can give ketorolac, either IV or PO. But if the patient is on lithium as well, then at that time we recommend either acetaminophen or sumatriptan intranasal. If patient had nausea in the previous session, so we can give antiemetics like ondansetron. If we decide to give that, we need to monitor the QT prolongation. There are some other medications like the medications which acts on D2 receptors, like metoclopramide, or that medications we recommend to avoid, as it might worsen the EPS-like symptoms. And Benadryl can also be given if you want to give. Inducing agents, the best inducing agent is the one which should have short half-life, rapid onset, and recovery in hemodynamic stability, minimal interference with seizure duration and seizure threshold. We can give methotrexate, propofol, etomidate, ketamine as an inducing agent. Other additional drugs like flumazenil we give to the patients who are on benzodiazepines for either for catatonia or for the anxiety. And if we decide to give flumazenil just before the ECT session, we need to give midazolam IV to stop having any withdrawal symptoms from benzodiazepine. Ramifentanil acts as a synergetic, specific for opioid M receptors. In ECT, it shows reduction of the the primary inducing agent, we can give the dose less. Neuromuscular blocking agents needs to be given. Succinylcholine is the one which we prefer, but if the patient has a history of deficient in serocolinesterase, rocuronium can also be given. Let's learn about the ketamine. So PCP as an anesthetic was first identified in 1956. By the time we reached to 1965, PCP, the use of PCP as an anesthetic was terminated because of its side effects of hallucinations, post-op confusions, and all. So in around the same time period, in 1962, ketamine, RS ketamine, was synthesized. And RS is mainly, it is a racemic mixture of S-ketamine and R-ketamine in equal measures. And the first study of ketamine on human as an anesthetic was done in 1964, and FDA approved the use of ketamine as an anesthetic and analgesics in 1970. It was also included in the list of essential medicine by WHO in 1985. Since 2000, Berman and his colleagues had demonstrated the rapid acting and sustained antidepressant effect of RS-ketamine in patients with depression. And these findings were replicated by several randomized double-blind clinical trials. And it was also reported that even after a single intravenous dose of 0.5 milligram per kg, improvement of symptoms was seen within 40 minutes of administration. In US, Ginseng Pharmaceutical developed S-ketamine nasal spray for the use of treatment-resistant depression based on the results of double-blind multicenter trial. The results were published by Singh and his colleagues in 2016. Around the same time period, Yang and his colleagues in 2015 and 2018, and Zhang and his colleagues in 2014 reported that the likely that R-ketamine plays a role in long-lasting antidepressant effect of RS-ketamine. Corio and Milo in 2019 did a head-to-head study for S-ketamine 0.25 milligram per kg intravenous infusion and RS-ketamine 0.5 milligram per kg intravenous infusion, demonstrated that S-ketamine produced a similar antidepressant effect to those of RS-ketamine in treatment-resistant patients with depression, indicating the non-inferiority of either of them. The antidepressant effect of RS-ketamine lasted 7 days after the single injection, were more potent than the S-ketamine. So on March 5th, 2019, ketamine nasal spray was approved by FDA for the use in treatment-resistant depression in conjunction with oral antidepressants. And as we speak now, several researches are going on to see the safety and efficacy for R-ketamine as a treatment for treatment-resistant depression. So next, mechanism of action of ketamine. As we just saw in for ECT, there are several hypotheses were are reported the same way. There are several hypotheses have been reported for to explain the mechanism of action of ketamine. NMDAR inhibition and mPAR activation. It hypothesized that the rapid antidepressant action of ketamine occurs via blockade of NMDARs located in the inhibitory neurons. And the activation of mPAR is required for ketamine's antidepressant effect. Similarly, in monoaminergic systems, several works are going on to identify serotonin and dopamine as the pathway mechanism of action for faster acting of ketamine. BDNF and tropomyosin kinase receptor B studies have produced that the prolonged activation of BDNF TRKB cascade in the prefrontal cortex and hippocampus is responsible for the long-lasting antidepressant effect of RS-ketamine. Yang and his colleagues in 2018 published research claiming the role of mTORC-C1 in the antidepressant effect of S-ketamine and the role of extracellular signal regulate kinase in the activation and the role of antidepressant effect of R-ketamine. Recent studies shows that pre-treatment with ripamycin prolongs the effects of ketamine. So similarly, in 2018, Dr. Hale and Hu demonstrated the blockade of NMDAR-dependent bursting activity in the lateral habenula along with low voltage sensitivity type calcium channel is responsible for the faster acting of antidepressant effect. And based on this theory, Yang and his colleagues in 2018 performed a research on rodents by giving ethosuximide 200 milligram per kg, a T-type calcium channel inhibitor, resulted in rapid antidepressant effects in rodents. Jiang and his colleagues in 2020 published a double-blind placebo-controlled study and demonstrated that ethosuximide did not produce antidepressant action in medication-free patients with depression. But still, a lot of research is going on in this line to see if ethosuximide, along with any other antidepressant or ketamine, is helpful for as an antidepressant. Williams and his colleagues in 2018 published a research in which the pre-treatment of opioid receptor antagonist naltrexone significantly blocked the antidepressant and anti-suicidal effect of RS-ketamine, suggesting the activation of opioid system was necessary to produce the rapid-acting antidepressant effects of RS-ketamine. Other separate researchers have published that naltrexone did not affect the antidepressant effect of ketamine, but still it's still studies going on to find out if the opioid system is involved in the mechanism of action of ketamine. Jiang and his colleagues in 2020 proposed that RNA synthesis, RNA sequencing analysis demonstrated that transforming growth factor 1 in the microglia plays a role in antidepressant effect of R-ketamine. Similarly, several studies are going on to establish brain-gut microbiota axis. A research on rodents have shown that ketamine improved the abdominal gut microbiota. So as we speak now, several researches are going on to establish the mechanism of action of ketamine. This is an animal study by two different scientists, two different researchers, and the publication involves, first one is Dr. Ronald Duman from the Yale University. And for him, the depressed mice, the mice which has gone through stress for some time in the lab, they have seen that they lose the dendritic spine on this is a neuron, and they lose the dendritic spine, which is mainly helpful for the synapses, formation of the synapses. So they see that these are lost, and after the ketamine, they see that there is a new growth of dendritic spine within the 24 hours of ketamine infusion. The same way, Dr. Corner from Vail Carnal Medicine investigated how ketamine affects the brain after mice experiences chronic stress. So this is the baseline of the neuron where we can see the red arrows are showing that dendritic spines are present, and after chronic stress, there is an increase of loss and decreased formation of dendritic spine. And this is within the 24 hours, they see the new growth of dendritic spine and resulting in synapses and connection. And further experiments showed that the newly formed spines were crucial for sustained reversal of the negative effects from stress. When the ketamine-induced spines were eliminated, the mice again showed the depression-like features. So now this is a randomized, double-blind, single-dose crossover clinical trial. This is trial 17 adolescents from age range 13 to 17 with a diagnosis of major depressive disorder with at least one failed trial on antidepressant on children's depressing rating scale score of 40 were included in the study. The study compared midazolam versus ketamine. The primary goal of the study was to assess the depression score using Montgomery Asperger Depression Rating Scale in 24 hours after the treatment, and the secondary goal was to monitor how long the effects last by assessing the depression scale on day 1, day 2, day 3, 5, 7, 10, and 14. And in this study, they have noticed that the single ketamine infusion significantly reduced the depressive symptoms in 24 hours after the infusion compared with midazolam. Here, the midazolam, this is a midazolam. The improvement of symptoms was seen somewhere, and the decrease in the score was somewhere around 24.13. But here, the decrease in the score is more. The patient's score, MDARS scores, have decreased more with ketamine. And also, the 76% of the sample, somewhere here, it is 15.44. And 76% of the sample had significant clinical response to ketamine after the first 3 days. Here we can see that 76. 35% of the patients had a significant antidepressant response to the midazolam, but 5 in this group, both 5 participants in this group both responded to both the groups. Now let's learn about the psychedelics. Psychedelics, the first time the mescaline was identified in 1898, followed by the synthesis of LSD in 1938. And after that, in 1959, psilocybin was identified. And since then, there were a lot of studies were done on human from 1997 to see the safety and efficacy of the substance, of the psychedelics. For the first time, researchers in 2019 at the UNC School of Medicine have discovered precisely what the drug LSD looks like in its active state when attached to the human serotonin receptor in the brain cell. And their first ever crystal structure revealed a major clue for why the psychoactive effects of LSD last so long. So what is the view of FDA on psychedelics? FDA identifies that psychedelic drugs showed initial promises response in potential treatment for mood, anxiety, and substance use disorder. And also there is a therapeutic potential which needs, the clinical studies needs to be done to identify the exact protocol. There is a draft has been provided by the FDA to help researchers design studies that will yield interpretable results. So that's why a lot of studies has been going on these lines. Let's see the effect of psychedelics. There are classic psychedelics are LSD, psilocybin, and ayahuasca, which is DMT. The mechanism of action is serotonin receptor agonist. It increases the cognitive flexibility, creative thinking, changes in the visual perception, mystical experience. It affects on the negative emotions of anxiety, labile mood, by causing the positive emotions like increase in well-being and self-satisfaction. It enhances the empathy and prosocial attitude. The other compounds are mescaline. MDMA is also a serotonin receptor agonist, but it acts on the acts on the other receptors also, like mixed serotonin, norepinephrine, and dopamine reuptake inhibitor and release. Deficits in the spatial memory, mild impairment and psychomotor tasks, changes in body perception, slight visual and auditory alterations, but there are no hallucinations. It affects on the negative emotions like distress and hostility, and increases trust and sense of greater meaning to life. It increases connectedness towards other and increase empathy. The other compounds in this group are MDA and MDEA. So ketamine is one of the psychedelics which we just learned before. So now MDMA. So so the group of the scientist, the Mithofer and his colleagues, did several studies to find out if its efficacy and safety, and also the dosage. So the randomized double-blind clinical trial, the sample size was very less, 23 on the PTSD patients. They compared the dose of MDMA of 125 milligram plus optimal of 62.5 milligram can be given as optional. And the placebo was lactose, and they significantly reduced in PTSD symptom severity. The mean change in CAP score 2 months after the second experimental session was minus 53.7 for the MDMA group and minus 20.5 for the placebo group. And the same with these patients were followed for 74 months, and they noticed that the significant and sustained reduction in PTSD symptom severity. Another randomized control study done by the same group. The patient's number of population is again less, that is 26, but the study is mainly done to identify the dose, optimal dose, and it says that a significant reduction of PTSD symptoms severity was there in all the groups, but there was decrease in minus 58.3 for 75 milligram group. The group which was getting 75 milligram, they have a score decreased to minus 58.3 compared to group which was getting 125 milligram. They had a reduction in score of minus 44.3, and the group which was getting 30 milligrams, they had minus 11.4 reduction in the score. So for the psilocybin, several studies of psilocybin has been published yet. The diagnosis the diagnosis which have been targeted were depression, cancer-related anxiety, tobacco use disorder, and alcohol use disorder. In all the study, it has been showing that there is a significant reduction in the depressive symptoms, and also there is a sustainability of the symptoms after this individual sessions with all the studies they have reported. LSD, randomized double-blind crossover study on 12 participants for anxiety associated with life-threatening disease. It shows that the dose was given for the participants for 200 microgram, and for placebo received 20 microgram. And they found that there is a significant reduction in state trait anxiety inventory score up to minus 11.6, and it maintained the anxiety level has been sustained for 12 months following up. And they also did a research on the healthy subjects, which shows that there is a positive effects, positive attitude about life or self, positive mood changes, altruistic and positive social effects. Ayahuasca is another study which has been going on, but sample size is very less, 6 and 17 for the major depressive disorder who are treatment resistant. The scores have been, it mainly shows that as after one session, the depression score was down to 62%, and then by 7 days it was 72%, and by the 21 days it sustained the effects. And both the research, both the open label studies have shown the same, that it reduced the significant reduction in the depression, and also it has a sustained effect until 21 days. Now let's learn about transcranial magnetic stimulation. Is the method used to deliver a stimuli through the scalp in conscious humans. It's mainly FDA indicated for FDA approved for treatment-resistant depression in 2008, obsessive compulsive disorder in 2018, chronic pain syndrome in 2013, and most recently smoking cessation. FDA provided marketing clearance for the device in 2020. The contraindications for the TMS is if the patient has patients with epilepsy, implanted medical devices like pacemaker, non-removable metallic implants above the neckline like cochlear implants, aneurysm clips, and DBS, ongoing substance use, a few of the contraindications for TMS. The techniques are mainly used as single pulse TMS, paid pulse TMS, repetitive TMS, accelerated TMS, which is Stanford model, and the theta burst stimulation. So now let's learn about the procedure, what exactly happens with these with the TMS. The first session is for brain mapping. It's mainly, in general, single pulse TMS is used to explore the brain functioning, and repetitive TMS is used to induce changes in brain activity that can last beyond the stimulation period. TMS applied over the motor cortex potentially activates the interneurons. Here, it potentially activates the interneurons, and and then after that, it on the plane of the parallel plane at the brain surface, and then this placement leads to transsynaptic activation of the pyramidal cells, evoking descending corticospinal tract. Motor neurons activation in response to corticospinal volleys induced by TMS leads to a contraction of the target muscles, evoking motor evoked potential, which is seen in EMG. And motor threshold is defined as a minimum TMS intensity sufficient to produce predefined motor evoked potential. For treatment-resistant depression, studies have shown the beneficial effects of repetitive TMS by targeting left dorsolateral prefrontal cortex. For OCD, studies have shown beneficial effects of RTMS by targeting orbitofrontal cortex and the supplementary motor area. Repetitive TMS protocols consist of identical stimuli, which is spaced by an identical interstimuli interval. At low frequency, RTMS is less than 1 Hz, and at the high frequency, it is more than 5 Hz. For theta burst stimulation involving like the burst of high frequency of stimulation, 3 pulses of 50 Hz repeated with ISI of 200 milliseconds. In a continuous TBS protocol, bursts are repeated for 40 seconds without any pause, and in an intermittent, bursts are delivered every 2 seconds and like there is an 8 second of pause, and it is given every 2 seconds, so repeated every 10 seconds in total. Now, as comparing with ECT, Dr. Richard Bermudes just reported, they published this research in which he compared repetitive TMS protocol 4 to 6 weeks, and he showed that the remission rate was 30% compared to the ECT, which is 50% getting ECT treatments 2 to 4 weeks. There is a new protocol produced, which is research is being going on, which is Stanford accelerates intelligent neuromodulation therapy. It uses ITBS, and its protocol is mainly like 10 sessions a day for 5 consecutive days. Each session lasts approximately 10 minutes with 50 minutes of break apart from between each session. And they claim that the remission rate is 80%. And recently, the update came on the same protocol, and they're still claiming that the remission rate is 78.2%. So now that they have done several pediatric testing of the TMS to see if there is any adverse effects since 2001. So the prenatal, if the patient has a prenatal stroke or autism, depression, these are the, they have taken the children in the somewhere from 11 to teen years, like adolescent, early adolescent to 18 years age group they have taken, and then it shows that there is no adverse effect, but treatments which was seen for the depression, patients who were getting for depression, they showed that there is an improvement in the symptoms and decrease and suicidal ideations have improved in 3 subjects in the patients out of 8 adults, but then the sample size is very less here. And now they did another study to find out if how the patients are responding, mainly the children of adolescents, early adolescents, late from 18 and 20.4 years with the mean. They have noticed that all the research have been reporting that there is an improvement in depressive symptoms, persisting for a long term, for at least 3 years follow-up. But Bloch in 2008 reported out of 9 patients who received TMS, 1 patient stopped treatment early due to anxiety and mood lability. 1 had hypomania and 1 attempted suicide 3 weeks after our TMS. Suicide is the second most leading cause of death among 10 to 14 years old and third most leading cause of death among ages 15 to 24 years old, with more than 500,000 attempts made by children each year. The American Academy of Child and Adolescent Psychiatry recommends that TMS intervention in children and adolescents with depression should continue for 6 months to a year, or a longer duration may be considered for those who suffer from more than 1 depressive episode. Let's learn about the vagus nerve stimulation. Vagus nerve stimulation is a type of neuromodulation technique that uses implantable devices to stimulate the vagus nerve, sometimes called as pacemaker of the brain. It is FDA approved for epilepsy in 1997 and for depression in 2005. It is also FDA approved for obesity. So the research, there are a lot of research done for the VNS. The gist of the research is that research published so far on VNS reports improvement in response and remission rate, which are sustained and significantly increased over 1 year following acute phase. Let's learn the mechanism of action of VNS. 80% of the fibers of vagus nerves are afferent, that is like it's projecting inwards. Vagus nerve projects to the solitary nucleus of the medulla and then projects to the median dorsal raphe nucleus and locus coeruleus. The key areas of serotonergic and noradrenergic interventions. A study published used positron emission tomography and analyzing the cerebral blood flow changes after VNS in 4 female patients with medically refractory depressive disorder. It demonstrated that VNS induced increases in cerebral blood flow in the prefrontal and the frontal regions and decrease in blood flow in the limbic region. In animal studies report that acute VNS is associated with global upregulation of neurotransmitters and increase gene expression of neurotrophic factors and brain-derived neurotrophic factors and fibroblast growth factor. An increase of left and right hippocampal volumes was found after the VNS. So they are correlating with neuroplasticity is also something going on up with the VNS. Transcutaneous auricular vagus nerve stimulation is a new recently being studied upon, and it delivers electrical stimulation to the auricular branch of the vagus nerve. The 2 most common placement are the anterior wall of the outer canal, which is tragus, and Simba concha. This been studying to find out the pulse rate, frequency, and the current to find out what exactly. Still, the research is going on these lines as well, as it is less invasive and we can see the more benefit of VNS. Deep brain stimulation involves implanting electrodes within the areas of the brain. FDA first approved deep brain stimulation in 1997 for essential tremors, in 2002 for Parkinson's disease, in 2003 for dystonia, and in 2009 for obsessive compulsive disorder. OCD is a disease of corticostriato-thalamocortical circuit involving orbitofrontal cortex, dorsolateral prefrontal cortex, ventromedial prefrontal cortex, then ventral caudate and pallidum, then anterior basal ganglia and anteromedial subthalamic nucleus and substantia nigra, with dorsomedial nucleus of the thalamus. It mainly, the pathology is in the OCD is the overactivation of the direct pathway out of proportion to the indirect pathway that leads to the pathological activity, overactivity of the cortical regions in the excitatory lobe in this way. Who are the appropriate candidate for DBS? The person who is diagnosed with OCD with a documented duration of at least 5 years, has severe OCD on the Vibox scale, have failed trial of at least 2 SSRIs, clomipramine, and augmentation with antipsychotics therapy such as exposure and response prevention. Who is not appropriate if the patient has a hoarding as a primary diagnosis, is not appropriate, has another severe psychiatric disorder such as personality disorder, a psychotic or bipolar disorder, or substance use disorder, has a cognitive disorder or dementia, is at imminent risk for suicide, or if there is an abnormal MRI imaging. So what is the location? This is various sites are proposed for the placement of electrodes. The striatum is among the most studied, followed by the nucleus accumbens. Data is amazing for these 2 locations, fortunately, but there are still new locations are being explored with both positive and negative results. A recent study published in 2023 proposes DBS at bed nucleus triaterminalis is showing promising results for refractory OCD patients as it generates very few adverse cognitive effects and improves cognitive flexibility after 12 months of stimulation. So what do we know so far from the research on DBS? Despite exhaustive use of optimal behavioral and pharmacological treatments, an estimated 10% of OCD patients remain resistant to all therapies and suffer from severe symptoms leading to marked functional impairment. Deep brain stimulation has been proposed as the last resort option for the treatment for these patients. The meta-analysis published in 2015 included 31 studies involving 116 subjects. The study reported global percentage of Vibox reduction by 45.1%, and global percentage responders were 60%. A clinical cohort research published in 2020 by D. Dennis and colleagues involving 70 patients, in which they followed the patients for 12 months post DBS and reported that their scores have been decreased significantly. With Vibox decrease in score for 40% reduction, Hamilton anxiety score decreased by 13.4 points by 55%, and for depression scores decreased by 54%. At the end of the 12-month follow-up, 36 of the 70 were categorized as responders, 12 as partial responders, and 22 patients as non-responders. As previous studies reported improvement of depression scores in addition to OCD scores after DBS, a recent work published by Alagapan claims that with the help of AI, the brain activity can be traced, and if a person is if a person will have a relapse of depression, it can be identified approximately 5 weeks prior for actual clinically if the symptoms appearance. So this is something new is going on in this field, and new researches are going on to find out how else we can help people with treatment-resistant conditions, psychiatric conditions. And that is my last slide. Thank you so much.
Thank you for a great talk, Dr. Bhimanadham. That was really interesting. Can you clarify when it comes to the psychedelic research, specifically the clinical trials that you showed for MDMA, popularly known as ecstasy, and psilocybin, how those treatment arms are set up. It made it, the slides made it seem like the treatment was purely because of the psychedelic. My understanding is that the psychedelic was used in a specific setting. Can you talk a little bit more about that?
Yes, so psychedelics are being used with the psychotherapy. It's been mixed with the psychotherapy sessions and still they are working on the safety and efficacy of not only the medications but also for the therapist who is being performing it. It works on the concept that after using with this psychedelics, the internal ego to stop to have the experience of the psychotherapy gets decreased, like the bond gets decreased, the bridge, like the patients usually not able to express themselves due to their internal inhibition, that gets decreased after this use of psychedelics. And the work is going on those lines to see if psychotherapy, and the medication psychedelics can show a good response, and still such lot of research is going on those lines.
Thank you. Any other questions? I think there's a question from the chat from Bianca Rome, and is Phoenix Children's using any of these treatment modalities?
At this point, we are not using any of the treatment modalities, but we would be we are working in the line of applying for possibly ketamine, to see the use of ketamine and for the children who are depressed, see if we can help children with that. So right now we are not using, but soon we will be planning to do research on that.
There have been a few cases where some of these modalities were used. We have a patient with severe OCD that has a DBS, and we have a couple of patients where we tried ketamine treatments as well. I think there's a lot to be learned from those patients, and a lot to be explored still. Can you imagine, Dr. Bhimanadham, what some of the barriers would be to translate some of the research from the adult population to the pediatric and adolescent populations?
A few of which is very evident is sometimes this research on the adult population is for treatment-resistant patients, and the way that it is categorized is at least they have to have 2 trials of the medications to its full high dose. So children, most oftentimes we don't see the treatment-resistant part, but then there is another ethical use also comes up, individual belief system from the parents, and also the providers. Like it's a lot of other ethical reasons also comes up to provide either ECT or ketamine or a TMS kind of protocol to the children. Another question is there any indication for using some of these treatment modalities in brain injury recovery like TMS? So brain injury recovery like TMS, I have to look into it, but while I was going through the through my research on for this presentation, I definitely came across that there is TMS, they are doing for TMS for children who have this stroke. Also, ECT is also, we can give, like I came across an article which mentions about post-stroke depression, and on those cases also we can give, but it's not like neurological improvement, but it's for depression. It's mainly for psychiatric reasons we can give them. But exactly for neurological reasons, I'm not sure about that.
No other questions. I want to thank you very much, Dr. Bhimanadham, for a great talk. Thank you.
Thank you.